So let's now talk about nerve injuries on a nerve-by-nerve basis, looking at the terminal nerves first. And we'll start with the easiest one to deal with because there's only one important muscle involved, and that's going to be the axillary nerve. Now, as we consider each of these nerve injuries, what we want to pay attention to is what happens, what is the functional loss associated with that nerve injury, how would you test it clinically, which in terms of the USMLE means how would they describe the patient in terms of observed losses, functional losses, and then the last thing we want to know is how is that nerve most commonly injured? What kinds of traumatic injuries, fractures or dislocations or sites of compression are most likely to be the cause of that nerve injury, so that they could ask you a question about a particular fracture or a particular dislocation and ask you about what nerve is most likely to be injured as a result of that traumatic injury. And they could either ask you about what nerve is likely to be injured, or they could skip over that and go directly to what are the functional losses associated with the nerve injury associated with that traumatic injury. So when we look at the axillary nerve, we said the only important function of the axillary nerve is the innervation of the deltoid. We said the deltoid is the major abductor at the glenohumeral joint, and so an injury to the axillary nerve would result in a loss of abduction at the glenohumeral joint. The way the axillary nerve is most apt to get injured is one of two ways, either a fracture of the surgical neck of the humerus or a dislocation of the shoulder. Now, the surgical neck of the humerus is the very upper part of the humerus, this region of the humerus right around here. And the axillary nerve, as it leaves the axilla, sits right up against the surgical neck of the humerus. So a surgical neck fracture can stretch or lacerate the axillary nerve, and that would result in a deltoid paralysis. So surgical neck fracture is one mechanism, and the other mechanism is dislocation of the shoulder. Now, surgical neck fractures, the only nerve endangered by a surgical neck fracture is the axillary nerve. With regard to shoulder dislocation, there are two nerves that are at risk. One is the axillary nerve, and the other is the radial nerve, and we'll talk about that in a few moments. So that takes care of the axillary nerve. We'll now turn our attention to the musculocutaneous nerve. That'll just take a brief moment because there's nothing much we need to say about that, because although what is shown on this slide, that the musculocutaneous nerve is responsible for elbow flexion and is responsible for sensation on the lateral aspect of the forearm, that's not terribly important clinically, number one. And number two, most important, the musculocutaneous nerve is rarely injured, and therefore it's not likely to be incorporated into a clinical vignette. The radial nerve, as I said, is the most frequently injured nerve in the upper limb. And one of the reasons it's injured so frequently is that it has a very long course, and in its travel it passes by several different locations where it's subject to injury. Now, because the radial nerve has such a long course and because it innervates so many different things, when thinking about radial nerve injuries, we have to pay particular attention to the level of the injury. Where along the radial nerve was it injured? Recognizing that only those structures that are innervated distal to the site of the lesion will be affected by that lesion. So a proximal injury of the radial nerve will affect lots of things in the upper limb, whereas a more distal injury of the radial nerve will affect fewer things in the upper limb because those structures innervated proximal to the injury won't be affected. So let's start off with the most proximal level for injury of the radial nerve, and that is injuring it in the axilla. Now, when you injure it in the axilla, that means you have injured it before it has innervated anything in the upper limb. And we know that what it innervates in the upper limb is the entire posterior arm and the entire posterior forearm, all of the muscles of the posterior arm and posterior forearm. And we know that the muscles of the posterior arm extend the elbow, the muscles of the posterior forearm extend the wrist and digits. And so with a with a lesion at the axilla, we're going to have a loss of elbow extension, wrist extension, digit extension. Now, this loss of wrist extension, that's an important clinical indicator, because wrist extension is the most distal function of the radial nerve that is a pure most distal motor function of the radial nerve that is a pure radial nerve function. So that by testing wrist extension, you've basically tested the distribution of the radial nerve no matter where the injury of the radial nerve may occur. Whether it be a proximal injury or a more distal injury, you would expect wrist extension to be affected, so that if a question were to refer to wrist drop, which means a loss in the ability to extend the wrist against gravity, that would be an indicator of a radial nerve injury. So you should associate the phrase wrist drop with radial nerve injury. There'll also be a weakening of supination, but that's not terribly important. Remember that there are no muscles on the back of the hand, so there's not going to be any muscular loss in the back of the hand, but the sensation to the back of the hand is from the radial nerve, or a branch of the radial nerve. So a radial nerve injury, no matter where it occurs, will result in sensory loss on the back of the hand. The way we injure the radial nerve up in the axilla is one of two ways typically. Either by a shoulder dislocation. I previously said that a shoulder dislocation can injure the axillary nerve, and so now we add to that it might also injure the radial nerve. A little later on, when we talk about shoulder dislocation, we'll see why that dislocation can affect those two nerves. The other way of injuring the radial nerve is by way of upward pressure in the floor of the axilla, something pushing upward into the floor of the axilla this way, because that would take the radial nerve and compress it against the humerus. And the two common mechanisms for that happening, one is a crutch injury, where a patient is supporting their body weight on the top of a crutch, with the crutch pushing up into the floor of the axilla, which of course is not the proper way to use a crutch, but when it is used that way, it can compress the radial nerve against the humerus. And then the other mechanism is what has been termed Saturday night palsy, which refers to an individual having his or her arm over the back of a chair and then falling asleep in that position, and thereby supporting their body weight on the floor of the axilla on the top of the chair. And that supposedly is related to having too much to drink on a Saturday night, sitting on a bar stool which has a high back chair. That's how it got its name. But in any event, upward pressure in the floor of the axilla compresses the radial nerve against the humerus. A bit more distally, we go further out into the arm, the radial nerve can be injured by a fracture of the humerus, the mid-shaft of the humerus. The radial nerve, through about 2/3 of its pathway through the arm, is almost directly in contact with the middle 2/3 of the shaft of the humerus. And so a fracture of anywhere along that middle portion of the shaft of the humerus thereby endangers the radial nerve. Now, when the nerve is injured at that point, in other words, more distally than the previous injury we talked about, the posterior muscles of the arm, that is to say the triceps, has already been innervated. And so an injury at that level doesn't affect the triceps, and therefore you will not have a loss of elbow extension. But it will affect the posterior muscles of the forearm, and so you'll have a loss of wrist extension and digital extension. And we'll still have that loss on the back of the skin of the back of the hand. If we go a little bit further distal, as the radial nerve crosses the elbow, just after it crosses the elbow actually, the radial nerve is in close contact with the head of the radius. So a radial head injury, either a radial head fracture or a radial head dislocation, can injure the radial nerve at that level. Now, since we're even more distal out along the radial nerve, not only has the triceps already been innervated, but many of the posterior forearm muscles are already innervated, since most of the posterior forearm muscles actually arise from the distal arm. So many of the posterior forearm muscles are spared, so you don't get a loss of wrist extension or digital extension, but you will have a weakness because you'll have some loss but not a total loss. And you'll still have the sensory loss on the back of the hand. And then more distally, the next place where the radial nerve might get injured is at the level of the dorsum of the wrist, where the nerve crosses quite superficially. Now, actually, at that point, it's no longer the radial nerve. It's simply the superficial branch of the radial nerve, remembering that there are no muscles in the posterior hand to be innervated. So the only nerve that goes into the only branch of the radial nerve that goes into the hand is to innervate the skin of the back of the hand, and that's the superficial branch. But that nerve crosses quite superficially, and so a laceration to the dorsum of the wrist or compression, let's say a tight watch band, can compress that nerve on the dorsum of the wrist. But because there are no muscles in the hand to be innervated by that nerve, there is no muscle weakness at all, but you will have the sensory loss on the back of the hand. So that takes care of the radial nerve. Going to the median nerve, we know that the median nerve innervates a lot of muscles in the anterior forearm and several muscles in the palm of the hand. The median nerve can be injured at two different levels, with the most common level for injury of the median nerve being at the wrist, and the second most common being at the level of the elbow. Now, at the wrist, there are two major mechanisms for injuring the median nerve. The most common median nerve injury is carpal tunnel compression. The median nerve is the only nerve that passes through the carpal tunnel. The carpal tunnel is a fairly tight space. It has 9 tendons and 1 nerve going through it. So anything that ends up occupying space in the carpal tunnel very frequently is simply a swelling of the tendon sheaths that causes it, but dislocations or inflammation can cause it. But anything that causes space-taking lesion in the carpal tunnel can compress the median nerve. And then the other mechanism for injuring the median nerve is a wrist laceration. Just before the median nerve enters the carpal tunnel, at the very distal forearm, it's in a very superficial position, so a wrist laceration, suicide attempts being a common cause of this, can injure the median nerve at the wrist. Now, because we're talking about a median nerve injury at the wrist, that means the anterior forearm muscles won't be affected. So only the muscles in the hand will be affected, and of course that very important function of sensation in the hand will be affected. Now, of the muscles that are in the hand, which ones are median nerve? We know that the 3 thenar muscles are median nerve muscles, and the first 2 lumbrical muscles are median nerve muscles. Now, the 3 thenar muscles collectively are what cause the bulge that we see at the base of the thumb. And that bulge is what's called the thenar eminence. So if those muscles are paralyzed, we're going to get a flattening of the thenar eminence. So a flattening of the thenar eminence means that there's a paralysis, a chronic paralysis. You're not going to see that with an acute injury, but with long-term paralysis of those muscles, they will atrophy, resulting in a flattening of the thenar eminence. Of those thenar muscles, remember the 3 thenar muscles are the flexor pollicis brevis, the abductor pollicis brevis, and the opponens pollicis. Now keep in mind that the flexor pollicis brevis and the abductor pollicis brevis are joined by other muscles that do the same function. There's a flexor pollicis longus and an abductor pollicis longus, both of which are muscles that come from the forearm. So if you knock out the flexor pollicis brevis or abductor pollicis brevis, you can still flex or abduct the thumb. But the 3rd thenar muscle is the opponens pollicis, and that's the only muscle that opposes the thumb. So the major functional loss to the thumb with a median nerve injury is loss of opposition. Loss of opposition. And that's a significantly debilitating loss because of the importance of using the opposable thumb in manipulating objects with your digits. So a loss of opposition. Now, when you have a long-term or chronic paralysis of the opponents, eventually the thumb at rest will be pulled around into an unopposed position by the remaining muscles that are not paralyzed. So you'll have what's called overriding of antagonistic muscles, pulling the thumb into an unopposed position. So the thumb will be in the same plane as your other digits, which is not the normal appearance, but that is what you see in your foot, where your big toe is in the same plane as your other digits. So over time, with a median nerve injury, you may see the same appearance in the hand, the unopposed thumb, and because that hand takes on the appearance of the hand of several species of ape that normally have unopposed thumbs, that's sometimes been referred to as ape hand. So we've talked about the paralysis of the thenar muscles. We've also made reference to that very important sensory loss in the hand, the 3.5 digits on the palmar surface of the hand. I'd like to hold off in the discussion of the first two lumbricals until we can talk about all 4 lumbricals. So let's wait until we've talked about the ulnar nerve to do that. Now, the median nerve can also be injured more proximally just before it crosses the elbow. So let's talk about median nerve injury at the elbow. The mechanism for that usually would result in that injury is what's called a supracondylar fracture. Supracondylar fracture is a fracture of the very distal end of the humerus. The median nerve crosses right in front of that fracture site, and so the median nerve can be stretched by the displacement that occurs with a supracondylar fracture. So when you injure the median nerve proximally, as you do there, everything that we've said about the median nerve injury at the wrist will still be true because the structures in the hand that get innervated will still lose their innervation, but now we will add to that the loss of function associated with anterior muscles of the forearm. So we'll still have the sensory loss in the skin of the hand that we talked about. We'll still have the loss of opposition of the thumb that we talked about. We'll still have the paralysis of the thenar and the potential thenar flattening that we talked about. But now we're going to knock out digital flexors, the long digital flexors that are in the forearm. So let's just think for a moment about the digital flexors. There are 2 major digital flexors in the forearm. One is called flexor digitorum superficialis, and the other is called flexor digitorum profundus. Now recall that half of the flexor digitorum profundus was one of those exceptions with regard to median nerve innervation in the forearm. So that means that all of the flexor digitorum superficialis is innervated by the median nerve, and half of the flexor digitorum profundus is innervated by the median nerve. And by half, I mean the portion that goes to digits 2 and 3. The part of the flexor digitorum that goes to flexor digitorum profundus that goes to digits 4 and 5 is innervated by the ulnar nerve. So that means with regard to digits 2 and 3, both flexors are paralyzed, superficialis and profundus, so you won't be able to flex digits 2 and 3. You will still be able to flex digits 4 and 5 because the ulnar nerve innervates the profundus. With regard to digit 1, the thumb, we again have 2 flexors. This time it's flexor pollicis longus and flexor pollicis brevis, but both of them are innervated by the median nerve. So what we're saying is that all of the flexors of the thumb and all of the flexors of the index and middle finger are paralyzed with a high median nerve injury, so you won't be able to flex digits 1, 2, or 3, but you will be able to flex digits 4 and 5. So if you ask a patient to take their hand and make a fist like this, when they attempt to do that, they will not be able to flex digit 1, they will not be able to flex digit 2, they will not be able to flex digit 3, but they will be able to flex digit 4 and 5, So in attempting to make a fist, they will do this. And that's been called the sign of benediction, an indication of a high median nerve injury. Again, we'll come back and talk about the lumbrical muscles a little later. And then lastly, we have two wrist flexors, two major wrist flexors, flexor carpi radialis and flexor carpi ulnaris. Remember that flexor carpi ulnaris is one of those exceptions. Again, that's a forearm muscle that's innervated by the ulnar nerve. So with a high median nerve injury, the flexor carpi radialis will be paralyzed. The flexor carpi ulnaris will not be paralyzed. So when you ask a patient to flex at the wrist, they'll only be able to use the flexor carpi ulnaris if they have a high median nerve injury. So in attempting to flex at the wrist, they will flex and pull toward the ulnar side. That's called ulnar deviation upon flexion at the wrist, indicating that they're only using the flexor carpi ulnaris because their radialis is paralyzed because the median nerve is injured. The ulnar nerve, again, can be injured at the wrist or can be injured at the elbow. At the wrist, the way you injure the ulnar nerve is usually by blunt trauma to the heel of the hand. The ulnar nerve, when it crosses the wrist, is not in the carpal tunnel. And so therefore it's superficial to the flexor retinaculum, so it's closer to the surface, so it's injured by blunt trauma, like falling on the outstretched hand. A direct blow to the heel of the hand can injure the ulnar nerve. We know that the ulnar nerve is the nerve primarily responsible for innervation of hand muscles, many hand muscles. And among those hand muscles, there are 7 of them that are called the interosseous muscles, and the function of those muscles is to abduct and adduct the digits. And so an ulnar nerve injury will knock out all of the interosseous muscles, and so the patient will be unable to abduct and adduct the digits like this. So asking the patient to do this would be a test for the ulnar nerve. They'll have a loss of the hypothenar muscles, the muscles at the base of the little finger. That's not clinically terribly important. And they will have a loss of lumbricals, the 3rd and 4th lumbricals, the lumbricals going to digits 4 and 5. So this might now be a good time to talk about the lumbrical muscles. So we have 4 lumbrical muscles. The ones to digits 4 and 5 are innervated by the ulnar nerve, and the ones to digits 2 and 3 are innervated by the median nerve. Lumbrical muscles all do the same thing. What lumbrical muscles do is they cause flexion at the metacarpal phalangeal joint while simultaneously extending at the interphalangeal joint, like this. So that's the function of lumbrical muscles. And so if you paralyze the lumbrical muscles, you'll have a loss of the muscles that do this, which means that now that you've unbalanced the muscle pulls that cross these joints, at rest, after a chronic injury, at rest, these joints will get pulled into the positions opposite this position. So if you're paralyzing a muscle that normally flexes at the MP joint and extends at the IP joint, that means over time, at rest, the hand will get pulled into the opposite position, which means extension at the MP joint and flexion at the IP joint. So the hand at rest, not when you're asking the patient to do anything, you're just looking at the patient's hand at rest, you'll see the hand in this position, and that's referred to as clawing. So clawing would be an indication of lumbrical muscle paralysis, primarily. Interosseous muscle contributes a little bit as well, but lumbrical muscle primarily. And since we know that the lumbrical muscles for digits 4 and 5 are ulnar nerve muscles, and lumbrical muscles for digits 2 and 3 are median nerve injuries, that means you could have a median nerve injury that causes clawing predominantly of digits 2 and 3, so the patient's hand might look like this. You could have an ulnar nerve injury that would cause clawing predominantly of digits 4 and 5, so the patient's hand would look like this. Okay? Now, an ulnar nerve injury at the level of the elbow would fundamentally have the same impact, since the major muscles that this nerve innervates are the muscles in the hand. So the same thing that we said about the hand is still going to be true, but we'll now also knock out that important muscle in the forearm. That's an ulnar nerve muscle, which is the flexocarpia ulnaris. So now when you ask the patient to flex at the wrist, they'll only be able to use the flexocarpia radialis, which means that they will get radial deviation of the hand upon flexion of the wrist. So if when the patient is asked to flex the wrist, if upon flexion they get ulnar deviation, that means it's a median nerve injury. If upon flexion they get radial deviation, it means it's an ulnar nerve injury. We're still going to have the same loss of the interossei. We're still going to have the same loss of the hypothenars. We're still going to have the same lumbrical loss. Now, we said that with regard to loss of lumbricals, a median nerve injury would cause clawing of digits 2 and 3, and we said an ulnar nerve injury would cause clawing of digits 4 and 5. That raises the question of what if the patient has clawing of all 4 digits? If the patient has clawing of all 4 digits, where would the most likely site for that injury be? And what we need to remember is that what all of the muscles have in common is that they are C8 and T1 innervated muscles. Regardless of whether they are median nerve muscles or ulnar nerve muscles, they're going to be C8 and T1 muscles. So if you have a paralysis that results in clawing of all 4 digits, the likelihood is that it's a C8-T1 injury, and the place where C8 and T1 are together so that a single injury can get them both is at the inferior trunk.